Hello and welcome. I'm your host, Neil Howard. Thank you so much for joining us for another segment of Health Professional Radio. In this segment, we're going to be speaking with Dr. Jay Wish. He's joining us from Indiana University School of Medicine to discuss the challenges of maintaining healthy phosphorus levels in patients. Welcome to Health Professional Radio. Dr. Jay Wish, thank you for joining us.
My pleasure.
Give us a bit of your professional background and talk about your role at Indiana University School of Medicine. And then let's talk about why nephrologists need to think twice about phosphorus management.
Well, I am a nephrologist. I'm on the full-time faculty at Indiana University, and my major role is to see patients in a teaching environment, and I also do some scholarly work, and one of the subjects that I've been interested in more recently has, in fact, been the treatment of elevated serum phosphorus levels in patients with chronic kidney disease, and more specifically patients who are on dialysis, because that is the most challenging population for this disorder.
So why is it so tough to maintain phosphorus levels when people with chronic kidney disease, and what happens as a result when these levels spike?
Well, phosphorus is in just about everything that we eat. Anything that comes from an organic source, whether it's a plant or an animal, has very large amounts of phosphorus in the cells. So we have continuously bombarded our gastrointestinal tract with phosphorus, which the body wants to absorb. And then in patients with normal kidney function, the kidneys get rid of the phosphorus that we can't use. So if you have kidney disease, and perhaps most importantly, if you have end-stage kidney disease requiring dialysis, your body can't get rid of the phosphorus, and the dialysis process itself is not very effective in removing the phosphorus. So the phosphorus builds up in the blood, and this produces a variety of clinical complications, the most important of which are the fact that the phosphorus complexes with circulating calcium, forming deposits on the walls of blood vessels, so that accelerates the process of hardening of the arteries. And more recently, it's been discovered that high phosphorus levels can elevate a hormone called FGF23, which stands for fibroblastic growth factor, and this stimulates the fibrosis of a variety of organs, including the heart and blood vessels. So high phosphorus levels, the major concern is an elevated risk of cardiovascular disease, which, as it turns out, is the major cause of death and hospitalization among patients with kidney failure.
So what's the current go-to management strategy?
Well, the major interventions that we use is basically to try to instruct the patients in terms of how to reduce the phosphorus content of their diet. Some foods are richer in phosphorus than others. The ones that are the biggest culprits are grains, beans, nuts, dairy products, etc. So we try to reinforce the importance of selecting relatively low phosphorus foods. But that's generally not effective because, as I said, almost everything that comes from cells is going to have some phosphorus in it. So then the next step is to try to prevent the ingested phosphorus from being absorbed by the gastrointestinal tract. And we do this with a class of drugs called phosphate binders. The phosphate binders basically, as the name suggests, bind with the ingested phosphorus and prevent it from being absorbed so that it's excreted in the stool. The problem with these phosphate binders is that they usually have a very high pill burden, meaning the patient has to take 2, 3, 4 pills with every meal to bind the phosphorus that's in the ingested food. And these phosphate binders often cause a variety of side effects, the most notable of which is constipation. So many patients decide they're just so uncomfortable from the constipation, as well as the inconvenience of having to take these pills simultaneously with food, which always may be challenging because they may not have the pills available when they're eating, especially, if they're out to a restaurant or something. So as a result, our success rate in lowering serum phosphorus levels among patients with renal failure is not very good.
So the drugs themselves actually work well, but they're just so inconvenient. There's so much of a hassle that there's mass noncompliance.
That is correct. And when you look at the actual success rate based on our ability to achieve target lowering of serum phosphorus levels in the dialysis patient population, which is best studied, less than 60% are in fact able to achieve those levels. So I like to think of it, less than 60% is a failing grade. Yes, whatever success we're having is great, but that's still 40 or more percent that are failing to achieve the target phosphorus levels, which puts them at risk for those cardiovascular complications that I mentioned before.
Now, it's my understanding that you've recently written studies that in part looked at the future of phosphate management. What does that future look like in your opinion?
Well, I think the major potential for improving phosphate management is to try to get away from this kind of long-standing paradigm, if you will, of giving these phosphate binders with every meal, which, as I said, the success rate over 30, 40 years that we've been doing this really has not improved. Even though there have been a variety of new phosphate binders that have been introduced over the last 30, 40 years, the success rate in the aggregate with all these binders still remains less than 60%. So we have to look at new mechanisms of action. And the most promising mechanism of action is a class of drugs that decreases the actual absorption of phosphorus by the gastrointestinal tract, independent of binding it with another agent. And the nice thing about that is that it's acting on the actual function of the cells that line the gastrointestinal tract, so it doesn't have to be taken with meals. And the most promising of these that has been tested and reported on in terms of clinical trials is one pill taken twice a day. So even though that particular approach may not be sufficient to lower serum phosphorus to target levels on its own, in combination with phosphate binders, there have been a number of studies that show that the dual effect of both the typical phosphate binder mechanism as well as this new mechanism is much more effective in getting the phosphate down to the target level.
Talk a bit about ASN's Kidney Week.
Well, the upcoming Kidney Week hasn't occurred yet. But I've had the opportunity to look at some of the abstracts that are submitted in advance and are available for public view. And there are several that actually examine the incremental benefit of this new class of drugs in combination with the traditional phosphate binders. And they all show an incremental effect, so that it's kind of like two is better than one in terms of the combination therapy that we often see with high blood pressure, diabetes. There's certainly a number of conditions and diseases where we just don't stop with one agent, but we use what's called step therapy and add additional drugs with additional mechanism of actions to get a better result. And that's exactly what we're seeing in some of these clinical studies that examine the new developments in phosphate binder therapy. So I'm very excited to actually go to this meeting, which is the first week in November, and actually hear the people who have done the research, describe the studies and hopefully have more discussion about some of the nuances and potential for the future.
Based on what you know going in, what should doctors and patients know?
Well, this is a new class of agents, and it has not been yet approved by the FDA, even though there are a number of clinical studies that demonstrate its safety as well as its effectiveness. And the FDA is actually going to be having an advisory board meeting on November 16th to decide whether or not to approve one of these particular drugs. So I think for people who are, in fact, interested in the potential for this new class of drugs to be implemented as a treatment for patients with high phosphorus levels, and we certainly need new treatments, then you can certainly explore the FDA website, www.fda.gov, do /advisory committees, and then you can do a search for November 16th meeting or the actual drug name, which is tenapanor.
Dr. Wish, I appreciate you joining us here on Health Professional Radio this evening, and I'm hoping that you'll come back and discuss what you learned at the meeting.
I look forward to it. Thanks very much for having me.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Jay Wish. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download at Anchor, Spotify, and be sure and subscribe to our YouTube channel at youtube.com/Health Professional Radio.